So we all will be getting one or two patients, pediatric patients in our dialysis unit, and whom we will have to dialyze to maybe for some time, and if they don't recover, maybe take on them for maintenance dialysis. And not all of us will have pediatric nephrology in our department, so it will be very difficult how to really choose the catheter size, from right catheter size to right dialyzer, to dose the heparin, dose medicines, and also do dialysis, then monitoring them. It will be a very difficult task. So to make this task simple, or at least not so difficult, we have Dr. Jyoti Sharma with us, who can guide us how to dialyze a child. Yes, ma'am.
So I sit behind you. On everything? Thanks. Thank you very much.
Thank you.
I'm really happy to be part of this CME. And it's very nice to see students from so many places. Welcome to the CME. So I'm going to speak. Am I audible? So message one is this, that though it may be true for some things, but for dialysis it is not true. So one size really does not fit all, and we are not going to, obviously, as Dr. Chakurkar has told you, that we will have to select all our wares for hemodialysis differently for children. The next slide is a bit of a disclaimer. So actually, I want this to be my next slide. So this is a slide to say that we all know, at least theoretically clear in our minds, though, and this is in the ideal world, that renal replacement therapy for CKD, the dialysis, whether we do PD or HD, is a bridge to transplant. More so for children because they have a very long life, and they have many years ahead of them. So we hope that they will have a transplant soon after they are initiated into dialysis. That's the ideal way, the world scenario, right? They can't survive on a dialysis forever. It's not viable. So leaving the transplant aside, the disclaimer is that though I'm going to be talking on HD because the CME is on HD, I want you to remember that for children, CAPD is preferable to HD. That is, you must think of it like this. And therefore I have put this slide here. And why is it? Is because it's continuous and more physiological, nearly steady state of body fluid, better middle molecule clearance. I wouldn't say very much better, but it is better than HD. Of course, if you're doing hemodiafiltration, that's a different story, but we're not doing it as a routine. Hypertension is better controlled, lower dose of erythropoietin is required, no vascular accident, no heparinization, and PD is associated with less risk of loss of residual renal function. At least we are able to maintain residual renal function for a longer time. And for children, there is a special advantage because they have a larger peritoneal surface area. It works better. We are able to do a better PD. Lesser dietary restrictions and fluid restrictions, therefore better nutrition and better growth. It's home-based and easier for normal activities for children. So we are able to, make sure that the cycles are adjusted. They can go to school. They can participate in many other activities. They feel less left out of the mainstream peers, and family vacations are possible. Their overall, their appreciation of life is much better. So psychosocially, it's much better. Just want to go back to this slide. And before we counsel parents and counsel them about any kind of dialysis, when you have a child with chronic kidney disease, this is the most important aspect which you need to know as nephrologists or budding nephrologists. That we have a child with chronic kidney disease, you can't rush in and start dialyzing them unless you have explained to them the implications of long-term dialysis, the implications for the child, and the implications of the rest of the family. Because you note that the child is not the only person of the family. In India, there is a large baggage of there's a huge baggage along with that. So the family is not just the child. The parents have to fend for many other family members. And they also have to look after their other children. If you go away with this message and carry this back with you, that please counsel the parents properly. This is an important part which we are not taught in undergraduate education. That you have to explain to them the long-term implications of dialysis, transplant, and how it is going to affect the rest of the family members. We are not just going to be treating the child, and even then, if we are managing the child, the long-term implications which are going to be there. Because it's sad not to dialyze a child, but it's even sadder to have to stop dialyzing or just lose them to follow-up after having them spend so much for the initial dialysis. So going on to more technical aspects, I'm going to be doing the talk in talking about the indications, vascular access, the extracorporeal circuit, the prescription, and outcome measures. So these are the few recommendations. So the National Kidney Foundation, the KDOKI guidelines say that you should consider, when the GFR is less than 15. Australian guidelines recommend that if the GFR is less than 6. And the Canadian guidelines talk about initiating dialysis when the GFR is less than or equal to 8. Just talking about few of our patients. So this is a 12-year-old girl. This is what actually happens. Diagnosed with nephrotic syndrome at 11 years. She was steroid resistant. Biopsy showed FSGS. Edema persisted. She was resistant to CNI. And you can see that she's very rapidly progressed. Her creatinine when she came to us was, or soon after she came, was 0.6. And obviously we came off immunosuppression and soon, and GFR has rapidly dropped to 10. Parents were counseled for RRT, but they, of course, went away when we suggested renal replacement therapy. But they came back a month later when she was really sick, and she was tachypnic with recurrent vomiting. She was hypertensive. Her urea had gone up to 200. GFR had dropped. So we had to quickly initiate HD. And then when she was more stable, we initiated CAPD. This is another case illustrating something a little different, just to bring to you that sometimes they can present so quietly and take you by surprise. This boy was really very surprising because he was 9.5 years old, who had some very insidious onset, vomiting and nausea, history of a seizure which was so brief that the parents ignored it, and it came up with history when we asked many questions. He was, his weight was at 50th centile, height was between 50th and 75th, so surprisingly very well grown, fairly well grown, mild pedal edema, but his BU was 375, his creat 27, GFR 2. So the only thing which told us that we have to initiate HD was the fact that his kidneys were really, really small. So that was an indicator, like we didn't have to wait for 3 more months or any such thing to define that it was CKD. And we had to explain, these are challenging patients when they're relatively well, and you have to tell the parents that your child has chronic kidney disease and we need to initiate dialysis. This is another indication which I want to illustrate, is that when you have a child who is non-oliguric, so typically a child with something like posterior urethral valves, whose GFR is okay, they are also, their potassiums are not bad. They never have hyperkalemia. And their acidosis you can manage with oral bicarb therapy, but their growth starts faltering even if you have control for everything else. And sometimes just that may be an indication if you can convince the parents, but that is an important indication in the ideal world to initiate maintenance HD or CAPD, which we would prefer. So coming back to the real indications, real life indications, when growth begins to falter, diminished activity, decreased appetite and nausea, often there is a combination of these before the parents actually agree for initiating therapy. Difficult to control hypertension, adverse biochemical parameters, I think these are common to adults. Now the last 2 indications I just want to emphasize, to permit provision for nutritional needs. Now this is a very important indication if you have an infant or toddler, because this group of children are dependent on feeds which are often partly liquid, fluids. So especially infants, where nutritional needs are in liquid form and they need to, the volume itself demands that you need to initiate some kind of renal replacement therapy to make space for nutrition. So it's very important for infant dialysis when it has to be initiated. And similarly, when there is nephrotic syndrome, especially when there is congenital nephrotic syndrome and there is severe proteinuria, you need to do nephrectomies. Otherwise, and this is also sort of a little far-fetched for us in our country. When you have a congenital nephrotic syndrome, the proteinuria is causing so much malnourishment that you have to do nephrectomies, initiate PD, and then till the child is old enough for transplant. Now, since we're talking about growth, I just want to talk about something about why so much importance to growth. And this is data from some of the large databases so this is the US renal data system where they have, the related morbidity and mortality with short stature. So the first one is talking about increased risk of hospitalization in children who have severe growth failure versus those who had moderate. I think the pad is very sensitive, much more sensitive than mine, so I keep this thing. Increased risk of hospitalization in severe growth failure versus those who had moderate growth failure. The NAPRETIX data is also North American pediatric renal transplant data, which says that those who had height SDS scores less than 2.5 had more hospital days as those who had greater than 2.5 SDS. The NAPRETIX data about mortality says that those who were shorter were more likely to die than patients with height which was in the normal range, understandably. This also extends to final height. So patients who had heights, standard deviation scores at start of RRT, who had good scores, had better final height, obviously, even if it was adjusted for everything else. So it seems that it not only affects final height, it also affects hospitalization, also affects mortality. So much for the predisposing, the growth and its importance. Coming to vascular access, so as in adults, in children, realizing the benefits of the low infection rate, the lower risk of access dysfunction and need for access replacement and better clearance. Now, lower risk of access dysfunction becomes more important in children, as you can understand, because the children are going to have, if they do not get a transplant, they're going to have a longer need or a longer duration for need of access. You can understand. So they cannot afford to have many access dysfunction. They're going to just run out of vessels, right? So therefore, AV fistula would come first. The problem is always that their vessels are too small, but it is supposed to be that it depends on the center, the expertise. So people who do use fistulae, they are centers of expertise where they only do use fistulae, even in infants. So what is the determinants of success of having AV fistula in children is a dedicated vascular access clinic where you have surgeons, physicians, nurses, everybody is trained and motivated to use it. So there are certain centers, I know for example, Gosh in London does it, then even Cleveland Clinic uses only these. So there are certain centers which have developed this expertise and they use only AV fistulae. So it's not as though it is not possible in children and not possible in small children. It's just has to be developed and you have to believe in it, I believe. Early referral and preparation has to be done because unlike adults, the fistulae in children take longer to mature, definitely never to be needled before 30 days and you usually need 3 months, as much as 6 months. Higher success rates have been recorded in children weighing more than 20 kilos, brachiocephalic fistula better, because, and rest is as in adults, non-dominant arm first, distal before proximal, etc. And there are no studies to, which have been done in children about selection of vessel size, etc. So despite all that is known about the importance of the and the advantages of vascular access fistulae, the choice, this is something which is recent data. This is the AJKD in 2019, and this is the International Pediatric Hemodialysis Network data. So what they found is that the vascular access choice in 552 children and adolescents, and they studied 870 accesses from 27 countries. And they found that even then, the access of choice still remains a central venous catheter, right, in most places, except, and even in the older children, right? Only in this last group, in children more than 15 years, it seems that the AV fistulas are almost reaching this. So, why is the AV fistula first not universally adopted is, as I already told you, perceived technical difficulties, lack of dialysis nursing expertise, and patient concerns regarding puncture pain. So those who believe in it do special clinics for them, and they educate them, etc. And paucity of experience in managing the complications. When is a fistula actually not preferred over a central venous catheter is when you anticipate a transplant within a year, or patient is likely to opt for CAPD or needs emergency HD. There is not enough experience and evidence regarding AV grafts in children. Are we going to have tea? Because I can see lots of people sleeping in the audience. Please wake up. I'm sorry if I'm sounding so boring. Okay, can somebody talk about central venous catheters? Vipul, you're really asleep. Wake up. You're distracting me by falling off your chair. Yeah. Vipul S. Any guesses? What is the kind of catheter you would use? Okay, I'll ask Neha. Neha, where is Neha? What will I use for a newborn? I can only ask people I know. Okay, Madhura. Poor Nivedita. Madhura, what will I use in a newborn?
Preferably we'll do a PD only.
Oh. Okay. Any guesses? Suppose I want to do. Okay, never mind. So if you really want to do, anybody? 2 single lumen accesses. Okay, so you can use the umbilical vein and peripheral vein. Okay, so you have to use 2 single lumen. So this is all textbook. But you need to know it, At least you should know what you can do. But you can, I'll come to the sizes later. This is the recommended sequential order of CVC placement, right? This you all know. And we also know that high risk of infection, risk of thrombosis, variable flow rates is why we don't use them. What is important is that you must know that we want to use the larger the better for flows and solute clearance, but a very large catheter is likely to cause injury to the lumina and you're going to have thrombosis. So we need to know sizes, right? And these are approximate sizes. So something like 6.5 French, 8 centimeter. What we have available is, we have a 6.5 French, right? So we have 6.5 French available to us, with us right here. And 8 French, 10 French are easily available. And the rest, of course, the bigger sizes are available. So you don't need to note down everything. I think Vipul is planning to give you a PDF of all the slides, of everybody's slides, right? So don't take photos, and it's just a waste of time. Listen, if you want any. So there's nothing here except technical things that you have to choose a size which is relevant to your patient. It is important to understand. And what is important to understand is that you have to have a target extracorporeal volume which you can't exceed or should not exceed. Otherwise, your patient is at risk for hypotension, right? So, volume of blood tubings plus dialyzer should be less than 10% of the patient's blood volume, which is 70 ml per kg for a particular patient, right? These are the important numbers to remember. So your extracorporeal volume should not increase 70 ml per kg. So the volume of this number I haven't changed. So, you know, most books mention 103, but the Fresenius we use is actually 160. And so we have to factor in the volume of the dialyzers also, which change with the dialyzers available. Currently, we are not able to lay our hands on F3 because they're just not importing it. And so we choose the dialyzer to match the surface area of the child's surface area. Is that clear? So the dialyzer size is chosen by matching the surface area of the dialyzer to the surface area of the child. And the surface area of the child is calculated based on the, where is Ajay? Ajay Haini? Okay, then it's fine. Vipul, how do you what is the surface area of the child based on? I'm not asking you the calculation. Based on what parameters? What do you want to know? Weight and height, right? So that's all you need. So we need to know that surface area you want to calculate. And so this is a 10-year-old child, 22 kilos, height is 130, BSA is 0.8, blood volume is 70 ml per kg, so 1540, everybody is sleeping. So accepted extracorporeal volume is 154 ml, right? Now we have to choose the dialyzer and a tubing. I'm sorry, I've not changed this because this last minute 160 has come up. So here I've corrected it. So if you were to pick up an F5 by a reflex, which I think would be the normal one which you probably use for a small adult, and you use 160 is the ml of the tubing which we use nowadays, Nipro is what we are using, then you would get a volume of extracorporeal volume of 250 ml, which would be too large. Which are the volume tubings which you are using in Nadiad? Do you have any idea?
We are using the Nipro.
So that's 160, I believe. We just checked, yeah. So, and anyway. So, if we use this, we would run up to a volume of 225, which would be too large. But if we use F4, we would be a little closer, but still too much, 210. So if you have a child who's not, really full, then you would run into a problem. In that case, if you have a child who you can actually run in saline, and then you would have to, target your ultrafiltration and remove fluid when you're coming off. But if your patient is already, are you understanding? Or you can prime your circuit with albumin, which of course makes it expensive.
End-to-end connect.
Sorry?
End-to-end connect.
End-to-end connect, yeah. Yeah, so that's another thing. Pediatric tubing has a volume of, I put it here, they are available, 73. That's the other option. That's the best option. The pediatric tubing currently available are single use. Not very, not so costly. But if you're dialyzing a small child, it's worth the cost, especially for the first few dialysis, we would use it. So blood flow, we would use something like 5 to 7 ml per kg per minute. And just a calculation, 20 kilo child would need that 100 to 150. This is also a bit theoretical because if you use 50 ml, you're at risk for clotting. So you generally, keep it around 100 at least. And anyway, we usually don't dialyze children less than 10 kilos. It's very risky, and we don't have the smaller dialyzers. And the dialysate flow would be twice the blood flow. And but the limiting factor is maybe your machine, because most of them would have a minimal dialysate flow of 300. Some may not go down below 500 also. It's safe to start with an ultrafiltration of 10 ml per kg, and you can go up to as much as 12 ml per kg, which comes to the same if you calculate as less than 5% of the body weight in one session. And of course, you can do the same principle of isofiltration as you can do in adults. And rapid ultrafiltration for the first 15 minutes, you can remove 1% of the patient's body weight or 1.5% of the dry weight over 30 minutes. So I think the difference is to be knowing the per weight and percentage calculations as per the child's weight and body weight and volume. That's the most important thing to remember. So you have to carry, if you're really going to be dialyzing children, then you have to know these figures or carry them with you on your cell phones. Anticoagulation, again, the loading doses and the boluses are per body weight. And I think that Snehal has already spoken to you about the no heparin option. So I'm not going to talk about it further. And measurements of adequacy, you have a whole talk after this, except for the second slide. Again, I'm going to be talking on. One is, of course, adequate UF optimal BP control. Growth, weight, and pubertal development versus normal growth. These are, again, very important parameters to assess your patient. So you have to know, be familiar with growth charts. You have to be able to assess puberty and refer to an endocrinologist if you're not able to manage or this thing. But if you're, you can't really do much about it also, but you have to know that your child is not doing well. And so be aware that there are normal growth charts and you need to refer to them. Clinical signs of malnutrition and serum albumin, NPCR is going to be part of the adequacy. Adequate psychomotor development, school performance, quality of life, well-being. Is the child able to take part in all activities other than his school is also very important. I'm going to spend some time on this. Vipul, how am I running for time? Very bad. Matlab, we've already finished half an hour. Don't. 5? Okay. Then I'll hurry up. Okay, so these are two, I'll just go through this very quickly. So these are suggested dietary intake guidelines, which give you protein and intake based on sort of international standards. They have been derived from published guidelines of many countries, many health publications. And they have been standardized by the Pediatric Renal Nutrition Task Force. And you must use these for prescribing and monitoring children to prescribe calories and proteins. So these are essential if you're going to be prescribing. So, and the importance of this also is the fact that, you know, for the first year they have prescribed every month, for every month they have changed the calories and proteins. And then for the, from 2 years to 15 years, they have gone on to do it separately. And, okay, I think I'll have to skip this. Then of course we know that just like adults, there are benefits of intensified dialysis regimes in children. So people are trying and using extended nocturnal HD at home, but the burden, care burden is too much, and most people do not accept it because they feel that their lives are, the caretaker burden is too much. Many centers have tried short daily HD in the HD center, which works very well in other countries because people have special educators coming and taking care of the school education as well as playtime while the child is undergoing short daily dialysis in the HD center. And of course, hemodiafiltration, and I think many of you would be familiar with this. This is the famous 3H study, which showed benefits of HDF. So this was actually an observational study where they enrolled patients some patients just underwent conventional hemodialysis, and then some patients underwent hemodiafiltration in different centers, and they just got the data together and compared age-matched and gender-matched children. And they found that there was an increased height SDS score, 24-hour BP. They, most importantly, so this growth was better, beta-2 microglobulin, low PT, and the PTH was lower, HB was better. So this is a very interesting study. Most important, you cannot be successful unless you have a multidisciplinary team for success. Nurses with expertise in caring for children receiving dialysis. We cannot do without them. We cannot do without them. Dietitians who understand CKD related nutrition and growth. And there's going to be a big kind of group developing nutrition for CKD children in India. And we're going to be part of it. And our dietitian is going to be part of it. Social workers and psychologists to support both family, the child and the extended family, which is part of the culture. Just a quick look at what happens to children. So we may have seen about 200 children who needed some kind of dialysis in our setup since 2014. So I just want to point out that many children just go home and withdraw from treatment. We have initiated RRT for 29, and I just want to show you that we use HD as a bridge. Most have gone on to CAPD. Some have been on MHD, of which 4 died, 3 were dialyzing elsewhere, 1 died in-house here, 2 have been transferred to adult, 1 has been transplanted. These of the CAPD, 14 are following up. Yeah. So, in conclusion, I would say that counseling is a very important aspect, and though the principle and goals of therapy are the same, we need to monitor the children closely for their overall development, and dialysis is a temporary measurement. Thank you very much for your patience and for listening to me. You may direct any questions that you have on the technical aspects of dialysis to Vipul and Dr. Lobo.
Thank you, ma'am.
Sir, you don't need to ask a question also.
That we are giving to in our adult population, the same can be used for children. What is your
So I don't know what you use for adults, but most of the times our dietitian manages to give them home-based food, sir. It's very rarely that she prescribes food which has to be bought from a tin. Very rarely she gives any formula. Most of the time she manages to somehow manage with the diet on which the child is. Another thing which you must know is that many children, especially the infants and toddlers, they need to have gastrostomies and aggressive feeding because they can't take that much with all the reasons for which they have the anorexia. It's not an unknown thing. We've just had 1 child with a gastrostomy because the parents here don't accept it so much.
One question from me. I'm Dr. Sudeep from Command Hospital.
Hi.
I'm asking a very personal daily question. As an adult nephrologist, I get stumped when a child comes to me for dialysis. My first question is, should I use the largest possible AVF needle if the child's vein can sustain, or there's some specific size or some ratio, some relation beyond which I should not be going, sir?
It will depend on the blood flow you want.
Sir.
Yeah. 17 French needle
yes,
is less than 2 millimeters. So it will easily go into a fistula vein, even if that fistula vein is not 6 millimeters.
Because we have a child, sir. We tried to find out, their parents were concerned that we want a smaller needle. So we tried our best, but we could not get anything 18 gauge, we didn't get.
You can use an 18 gauge intracath if you want.
Okay, sir.
It can be done.
Okay.
If you want a smaller one, we've done in Sassoon when we didn't have fistula needles, we used to use intracath.
So we'll remove that trocar and
remove
use
the trocar. You puncture just like you would puncture for putting in an intracath, and then pull it out. You can even shorten the intracath if you need, because the intracath is longer than a fistula needle, and resistance length is in the numerator. So the longer the length, more the resistance. So short is.
And ma'am, another thing, we have a child on perm cath for dialysis for almost 2 years. Now he's not gaining any weight. So how do I come to know whether his growth is retarded? Am I doing inadequate dialysis? He's not gaining weight. And how do I know that whether sometimes he's puffed up, sometimes he's not. So I'm actually at a loss completely to what, should I do some improvement in dialysis or should I continue like this? Yeah. Okay.
Very difficult to say.
So, is there some simple parameters to realize that child is not gaining weight? And last problem with the same child, he grew a.
If he's overloaded and puffy, then you obviously.
Sir.
Sorry. If he's fluid overloaded and puffy, then obviously he needs to have that fluid out. And if you do the formal KT by V and NPCR, that will give you many answers, I think, comparing the two. Yes, and of course, all the other parameters of his, the hemoglobin and the, the serum albumin, everything put together should be able to answer all your questions, including plotting his growth chart, his mid-parental height, right from all that to the biochemistry. I don't think it will be difficult to... I think Suprita is going to be here soon.
Yes, ma'am.
So your problems will be solved.
But still we keep getting posted to places.
No, but I think that if you put down all this, if you like, we can share some algorithm with you. Yes. Or you just send the patient once and we may be able to put it down.
Yeah.
Either ways.
Yes. Yeah. And one last thing, ma'am. This patient had multiple, 2 CAPD failures. So we switched over to perm cath. I did get a AV fistula made. But parents are just not ready because child cries putting a AV needle.
How old is the child?
Child is, ma'am, 11 but stunted growth. Mm-hmm. And this chap, now he grew candida in the, perm cath. And we tried to convince the parents to remove it, but they were just not ready. I don't know how.
That may be partly contributing to his failure to thrive. Yeah. I mean, how can you have candida there and not... you have to just remove it.
Yeah. But he's still on it. He's still on it. Patients did not
agree at all. I think that
you
just have to remove it.
Can I ask him one question? Sudeep, do you use local anesthetic for putting in fistula needles?
Sir, occasionally, not regularly. Because we have...
It may just help.
Yes, sir.
We infiltrate the fistula, even in all our adults, with an insulin syringe, 26 gauge needle on an insulin syringe, infiltrate the skin and then put in the fistula.
Right.
And you can show him the other child having his fistula being pricked.
I'll definitely take help, ma'am.
No, you can show him the other child who's having the fistula pricked, no? Yes. That will, I think, inspire him. But I think you have to get that catheter out.
Yes, ma'am. Yeah. Thank you very much, ma'am.
Listening to Colonel Sudeep, I feel I'm very lucky to have a nephrologist with us. Secondly, about the fear of pain for fistula, it actually applies to adults also. They do also get pain. So use local anesthetics whenever it is possible to use
A lot of the fistula malfunction is because of people using area puncture to avoid pain. Yes. And by the time the patient comes to us, and this is all adults I'm talking about, the fistula is ruined.